Okay. All right. Good morning, good afternoon to everyone who's logged in. I'm Brad Rockwell from Plastic Surgery, transmitting to you live from the Helix building at the University of Utah. Thank you for everyone logging in. We have a special guest today, Dr. Papa Fiifi-Yankson, who's a Finnish plastic surgeon and current hand fellow from KNUST and Komfo Anokye Teaching Hospital in Kumasi, Ghana. Pop is here as part of a traveling hand fellowship that he's won through the American Association for Hand Surgeons. Yep, thank you. Sorry. And he spent 2 weeks in Boston and 2 weeks in Philadelphia as part of that traveling hand fellowship. And now he's been here for 2 weeks, and this is his last week here. So he's going to present to us on a variety of topics. One of them will be the plastic surgery training in Ghana. And then he'll present a few cases that he and I and others have done together in the 13 years that I've been visiting his hospital in Ghana. And then we'll have a short bit on the hand fellowship. And the University of Utah has been an integral part in setting up that hand fellowship. It's a combined endeavor between Komfo Anokye and the Ghana College of Physicians and Surgeons with the American Society for Surgery of the Hand and the Center for Global Surgery at the University of Utah. So now I'll turn this over to Dr. Papa Fiifi-Yankson.
Thank you very much, Brad. Thank you for inviting me. So basically, I'll be talking about the collaboration between our center in Kumasi and the University of Utah. This will be the outline of my presentation. I'll talk briefly about the healthcare system in Ghana. I'll talk about how to become a surgeon in Ghana with a bias on plastic surgery. And then I'll dwell more on the Ghana-Utah collaboration. And then after that, we will have some discussions. On our Zoom link, we have the faculty at Kumasi. We have a head of unit, Dr. Hoyt Williams, also Professor Agbenoku and Dr. Joseph Akpalo will be joining us. We also have residents in Ghana joining us. All right, so Ghana is a country on the west coast of Africa. As shown over here, it shares boundaries with Cote d'Ivoire, Burkina Faso, and Togo, and the Gulf of Guinea. This picture here is the hospital where I practice, Komfo Anokye Teaching Hospital. So I'll talk briefly about the healthcare system in Ghana. We have multiple primary care centers in most of the towns and villages, and then we move a step higher to the district hospitals, which are kind of the main referral points in the various districts in Ghana. And then we have the regional hospitals. There are 16 regions in Ghana, so there are about 16 regional hospitals. And then they move to the bigger referral centers, which are the teaching hospitals. There are 5 teaching hospitals. These teaching hospitals are level 1 trauma centers. They usually have medical schools attached to them. And that's where most of the referrals from the primary care district and regional hospitals go to. So Komfo Anokye Teaching Hospital is one of such teaching hospitals. And when it comes to postgraduate training, there are basically 3 institutions that undertake postgraduate medical training. That's the Ghana College of Physicians and Surgeons, which is based in Ghana. And then we have the West African College of Surgeons and the West African College of Physicians. So to become a surgeon in Ghana, you basically have to do 6 years of medical school after high school. And then you do 2 years of compulsory internship, which we call housemanship. After that, you would have to work as a medical officer for 1 to 3 years. And then you write entry exams and start your residency training in whichever field you choose to. But I'll be biased on surgery. So for surgery, you have to do 3 years of membership, which is like general surgery. And then after your 3 years, you are a specialist, so you're posted for 1 year at least, and then you start your fellowship training, which will take 3 to 4 years, depending on the subspecialty you choose. And afterwards, they recently introduced the post-fellowship courses, which I'll be talking about later. So Ghana and Utah have been collaborating for the past 13 years. Basically, our center in Confanoche and the University of Utah through the Center for Global Surgery have been collaborating, and we've achieved a lot through this collaboration. It started out as a capacity building and venture, and now we realize that it's been sustainable. So there's been capacity building and sustainability. So it started out with a visit from a visiting plastic surgeon. And in the first few years, the nature of it was to gather complex reconstructive cases and do them together. And that's achieved a lot. But in the subsequent years, we stepped it up higher with themed presentations and with focus on particular surgeries. So we had about 3 years running with our focus on breast reconstruction and breast aesthetic surgery. So during those years, the faculty from University of Utah came and took us through basic breast reconstruction procedures using pedicle flaps, reduction and mastopexy. And through that partnership, we launched out our breast reconstruction awareness week, where we had a lot of media engagement on the availability of breast reconstruction for people undergoing mastectomy. And this has helped in the sense that aside equipping surgeons there with skills and ability to do these reconstructive procedures, it has also encouraged a lot of women who have had breast cancer to accept mastectomy so that they can have breast reconstruction done. So after the years of our breast reconstruction program, we moved on to cosmetic surgery, and namely abdominoplasty, liposuction, body contouring, and fat transfer. And through that too, there was skills transfer, and we've been able to do many more surgeries after the visits of our visiting surgeons. And the last on the block was the development of the post-fellowship program in hand surgery through the Ghana College of Physicians and Surgeons and the University of Utah. All right, so these are some papers that were published as a result of our collaboration. One on inferior pedicle breast reduction for the management of gestational gigantomastia, another one on breast reconstruction, and then the last one, which actually won an award on the PRS Global. All right, these are more papers that have been published as a result of our collaboration. And so if you go onto our account on Instagram, HW Plastic Surgery GH, you see a lot more photos of people who have had cosmetic surgery. And this is all as a result of the partnership that we had with the University of Utah. So these are pictures that basically show the visit of Professor Brad Rockwell, who has been the main collaborator between us and the University of Utah. these are some pictures taken in theater during his visit. This is one of the cases of breast reconstruction that we did during the Breast Reconstruction Awareness Week. This is another one. So in the video here, actually, it's a resident going through the markings for breast reconstruction, and it's all part of the skills transfer that we've acquired through this collaboration. These are some of the complex cases that we had to do. Intraoperative pictures. And then it's not all theater or OR work when they come. We also go out to have fun. So these pictures were taken during those outings. You can see here the current chief of plastic surgery at University of Utah. He was in Ghana some years back. Yes, so going forward, we hope to build up more capacity, especially in the area of microsurgery. And we've already started discussions, and we hope that that will come into fruition. We also hope that this partnership would evolve to include other subspecialties, not just limited to plastic surgery. And then we hope that with the development of this collaboration, there will be avenues for exchange, an exchange program for residents, so that the residents in Ghana can come here and experience what goes on here, and the residents here can also come to Ghana and experience what goes on there. And then we also hope to collaborate more in research so that we will publish our findings to the world. So yes, I'll pause here so that maybe we can have more interaction or discussions on what I've said so far, and maybe through these discussions we may come up with more areas that we can collaborate on. So this picture is shows Professor Benoku, Professor Brad Rockwell, and Dr. Emmanuel Ledu doing his inauguration at the West African College of Surgeons. Thank you. I'll hand over to Brad.
Thank you, Papa. That was very good. I think we have a few people logged in who might be willing to contribute in a discussion for this. And one might be Professor Agbenerku. Pius, I won't be able to see, but if Pius, if you're logged in, please just unmute yourself and let me know. All right, while we're waiting, I know Paco Hoyt-Williams, the Chief of Plastic Surgery at Confo Noche, is logged in. All right, Paco, I can see you. So one issue with the plastic surgery training. Sorry, we're just trying to, you want to turn up the volume? Okay. All right. So one issue with plastic surgery training was incorporating not only the very good training within Ghana, but also having the residents travel outside the country. Several of the residents have gone to India. Paco himself spent a year in Taiwan. And Paco, we're just wondering what your thinking is on traveling and training outside the country, what the benefits are, whether you think it should just be certain residents or all residents. But thank you for contributing.
Thank you so much, Professor Rockwell. Great to see you in a long time, and greetings to everybody listening. I had an experience in my training where I had the opportunity to travel to Taiwan and India. But basically, if I recount my experience, the greatest gain for me during these rotations were the desire to lead, ambition, and to know that everything is possible if I put my mind to it. I noticed that these countries, especially in India, had come a long way, and seeing where they had come from and what they could do at that moment within a considerable period, I realized how much we underutilized our resources and our potential as individuals. So basically, I remember when I came back, I put my team together, told them what could be possible, what we could do together. And one of the guys who spearheaded these ambitions was Professor Rockwell, when I explained a lot to him about what I believe we could do. And this is one of the things that have won the number of sub-fellowships we are trying to develop. I mean, successfully, the hand fellowship has been developed. In the pipeline, we are thinking of a breast fellowship, a burns fellowship. And not only that, it was our ambition because we identified the challenges in training within our sub-region. And one of them was research, and the residents had to produce a dissertation. So we thought at a point where we could even produce a regional kind of fellowship in plastic surgery, not to only attract fellows within our country, but fellows in the whole sub-region. And these are programs that we are still developing. And these led to various things we did for the first time, like having the first International Breast Surgery Symposium, having participants from Nigeria come to learn breast surgeries, both reconstruction and aesthetic surgeries, you know. And so basically, my exposure abroad in three things gave me desire to lead, ambition, and to realize that it is possible, and it is possible within our environment, because I had seen it being done. I mean, they show you the history, they show you what they used to do in the past and what they are doing now. And that has been my greatest gain in my exposure abroad. There are numerous, but these would be the most significant gains in my exposure. Thank
Great.
you.
Thank you, Paco. Can you answer one other question? So I know when you went to Taiwan, you were able to scrub in and fully participate. We have an issue in Utah, and I think most other states, and Dr. Jayaraman is trying to reverse this, but as of right now, the government in Utah will not allow people who do not have a U.S. medical license to actually scrub in and touch a patient. Would you have an opinion on the benefit of, say, what we could offer now in Utah would be someone coming and watching, but unfortunately not being able to scrub in and touch the patient? And could you assess what the benefit of a rotation like that might be to your residents?
Great. I think the level of our residents who would probably come to Utah are those who are theoretically sound, have the principles. At a certain level, you have experience, you've done it, you've seen your mistakes, you know the steps. And I believe that at that level, for instance, Fifi being with you, he's done his, let's say, breast reconstruction using tram flap, for instance. He knows how he does his in his head. He knows his techniques. If he observes at his level, he will be able to pick quite a significant amount. Certainly, it will not be the same as hands-on experience, but at his level, just observation will be good enough to polish up or improve his skills. There are places where you'd have the privilege of scrubbing in for sure. And of course, that comes with the benefit. That also comes with the extra benefit of when you think you have grasped the concept and you are doing it, you realize the coordination might not be that straightforward, but then you have the other person to correct you to know how to do it. This would be lacking in your environment, for instance. I've been in an environment where I had to see and watch when I was in India. I went as a very young resident. And basically what I was observing was lots of cleft lip surgeries. You know, when I went through the theory, I could draw it, etc. When I came back to Ghana, anytime I started doing it, I could recount what I used to see and how they overcame that challenge or that problem. You know, and it was quite helpful. So I think there's a role for now in any form of exposure. And for sure, it would have been great to be able to see, to do as well. But if that seeing is what's available, I mean, within the laws of your country, we don't have much of a choice, but it also has a benefit. Yeah.
Okay, Paco, I'm going to give the same question to Papa, who's right next to me. I'm going to turn the computer over. So Papa's been here for 2 weeks. He's also spent 2 weeks in Boston and 2 weeks in Philadelphia as part of the Hand Fellowship, and maybe just get his impressions on the same question. I think in Boston and Philadelphia, he was also observing, but not able to scrub in.
All right, thank you, Brad. I think like Dr. Hoyt Williams said, observing has some benefits. Of course, it's not as having hands-on, but you still get to pick up skills. You already have an idea what surgery they are going to do and how they are going to do it. So as you observe, you pick up things, how they do things differently, and you try them on when you go back. And I think aside the observership, I've also had both in Boston and over here, I've had the ability to use the micro lab, which has no restrictions. And so I think that the hands-on there can come in handy when I go back. So observing has some benefits. Occasionally, like I did here, there are some things that there's some kind of surgeries that are done here which are not done in Ghana. So observing it would at least give you an idea. You see in practice what you read in the books, and I think that you can adapt it to fit the system when you go back. And I think that through the observations I've done here, I've picked up a lot of things which I'm keen on putting into practice when I go back to Ghana. Thank you.
Okay, thank you, Papa. All right, Paco, don't go away, but I want to go to Emile Tano. Emile, bonjour. So Emile, if you unmute. We're still not hearing you.
Yeah, hello. Here is bonsoir. It's evening here.
So
Emile, yes. So Emile, I'll give you a little introduction. So Emile is a native of Cote d'Ivoire. So French is his native language. And then Emile went to medical school in Kumasi. And I think that's your first basic exposure to English was your first year of medical school.
Yeah, I spent a year at the Institute of Languages before I started medical school. So I had a year at the Institute of Languages before starting my medical studies in Ghana.
So Emile is also a plastic surgeon at Comfo Noche Teaching Hospital in Kumasi, same hospital for Papa and Paco. He was the first hand fellow in the hand fellowship that's been set up. From what I understand, there was a spine fellowship that existed, and then the hand fellowship is the second postgraduate fellowship within Ghana. And Emile was the first hand fellow, and Papa is the current and second hand fellow. So Emile, I was hoping to get your impressions on sort of what the hand fellowship did for you, mainly your comfort level doing hand surgery cases before the fellowship, after your plastic surgery residency, and then your comfort level doing hand surgery now that you've finished the hand fellowship.
Thank you, Professor Brad. I must say there have been a lot of differences. You know, because every subspecialty that you are doing is like you are skewing towards that. And therefore, you are going to pay attention to more details that you are going to do. I must say the contribution from Professor Don Lalonde and yourself has really been a game changer. Because being a plastic surgeon, yeah, it's true. We have read most of the time is under duress because you want to pass your fellowship exam. But when you come down, you want to do a subspecialty in the field, that requires a lot of attention, a lot of details, and also paying attention to what others have done and the experiences that others have done. And when they share with you, it really helps you to really beef up your knowledge. And also, even though far away, some kind of skill transfer as well, even though it's not on the field, but some kind of skill transfer. And then I must say, reading wide also, the program also have really opened my knowledge as far as academia also is concerned, because you need to read, try to see what is done elsewhere, read papers, and even sometimes we go beyond that, watching videos and so on and so forth. So I must say that being a plastic surgeon doesn't mean you know it all. Going to the subspecialty, it's like some kind of refining your skills, paying attention to details, and also now the eager to take new challenges and then to do it and do it well. So for now, that was I can say, Professor Brad. Thank you.
Yes, Emil, thank you. Okay, and we also, Professor Pius Egbeneku is now logged in. I think, Pius, if you can hear me, could you unmute and maybe we ask you for a comment?
Yes, thank you, Brad.
So
sorry, I've been busy the whole day at the presidency. You know, Ghana colleague had an appointment with the President Akufo-Addo today, so I just came back from that meeting.
Yes, well, thank you. Could I
join?
Yes, could I get your opinion on one question? Just earlier in the talk, Papa presented the number of years of training that are required to become a surgeon in Ghana. And I should mention that Professor Egbeneku is now, as you give me the official name, really the chief of surgery for the Ghana College of Physicians and Surgeons. So now, within the United States in the last 15 to 20 years, there's been a push to shorten residencies, mainly as a money-saving measure. Just in general, the federal government pays the salaries for residents, and by shortening the number of years, that would save the federal government some money. And I know within Ghana, orthopedics is now starting a program to shorten the training of their residents. And I was hoping to get your opinion. Is that good? If it's successful for orthopedics, could plastic surgery and general surgery and the other surgical areas adopt the same training program?
All right, thank you, Brad. The reality is that orthopedists are trying to shorten their training by 1 year, not in the training process itself, but all put together. In Ghana, if you finish membership, you need to go to the district to work for 1 year before you start a fellowship. But the orthopedic program did not go outside. The new program, you continue your fellowship soon after the membership. So you are saving at least 1 year from the training program. The fellowship remains the same 3 years, even though they wanted 4 years earlier on. So they are doing 3 years membership and continue with a 3 years fellowship, 6 years. Whereas in the past, it would have been 7 years plus. So I think that that's a good move to get a lot of specialists in the short term or a lot of fellows in a very short term. We can apply this to other courses as well, like plastic, urology, general surgery. We can apply this if only the people are willing, if only our authorities are willing to say that, okay, after your membership, you continue your fellowship training straight away. Because the membership program effectively is 3 years. In some countries, they do for 2 years. But the Ghana one, all membership programs are 3 years. So our surgery is designed to be 3 years for membership. But coming to plastic, to do it for 2 years, that will be difficult. So what I can advise is that the plastic, you do not go outside also to do 1 year post-fellowship or post-membership, but just continue straight away and do a 3 years member fellowship. And then you are saving 1 year. And that will be helpful to get more fellows produced within a shorter time. Thank you.
Yes, thank you, Pius. Okay, so we also have on the line Zainab Schumacher. Zainab, if you could log in. So Zainab finished the residency a few years ago, is now practicing in Accra. Zainab, could I ask you, I don't know for sure, but did you travel outside of Ghana during part of your residency?
Yes, not officially, but I did do a few observerships. That was just during my vacations, but these were in Germany. Whenever we went back home, just like short stints, but not a formal travel fellowship or anything like that. Yeah.
Yeah. And so now you're practicing in Accra. You're the only plastic surgeon in your hospital.
Yes, that's right.
Are there any areas of your practice that you feel could benefit from additional training or more broad training?
Oh, of course. Sorry. Yes, indeed, especially I'll say in the area of microsurgery. Yeah, I see that a little bit more training would could empower me to do more daring stuff than what I currently do. And yeah, I mean, a fellowship in whatever, hand or breast, aesthetics, anything. I mean, it's always an opportunity to enhance your practice and improve the care that we give to our patients. So yeah, it could be beneficial.
Yes.
Yeah.
Okay. Well, thank you, Zainab.
Thank you.
Can I go back to Paco? So I have Paco, a question on microsurgery. So in the 2 weeks that Papa has been here, just coincidentally and fortunately, our twice a year microsurgery lab training occurred last week. So 2 days, Papa was under the microscope in the lab practicing. He thinks microsurgery with loops might be an option. And I'm wondering if you would have an opinion on that, and how we might get microsurgery started, and would there be anything here at Utah we could help promote microsurgery?
Great, thanks, Professor Rockwell. Yes, there's a lot that can be done, and I'm happy Tutha is listening and is alert to hear the list I'm going to provide. I'm going to request. Basically, I think Papa being interested in microsurgery is one of the most important things. Interest, you know. And I did my microvascular surgery course a little bit in Nigeria. It was just like 2 days as well. It was 1 week program in FLAPS and microsurgery course. And I think within those 2 days, I understood the basics. Of course, prior to that, I had been working with Drs. Akpalu, Professor Gbenoku, who were doing some form of microsurgery during my training as well. So augmenting it with that exposure, you know, and we improvised. We used a regular microscope actually, and I used lab rats vessels, you know, with microsurgical instrument. And I was able to able to do something. We're using my loops. Once we had a visiting surgeon, he's Nigerian origin, Momo from Michigan. And we had a program where we're going to do deep inferior gastric artery perforator flap for breast reconstruction using surgical loops, which was successful. But though we just did it once and that program didn't, there was no sustainability, and he didn't come again. But that made me realize that, look, some very good amount of microsurgery can be achieved with surgical loops. And I know there are surgeons out there in the US who do majority or most of their microsurgical anastomosis using surgical loops as well. What would need? First, we'll need some exposure, and that's the key thing. Like Papa, what I would suggest is that it will be good to have a team exposure. If that is possible, this could be a week. You could have a surgeon, a nurse, you know, whatever role the nurse has to play, and this will form a microsurgery team. And once we have this team in place, now their aim is that all hand surgeries hitherto that they will give an excuse that no operating microscopes are available, transfer to Accra. These cases will be cases they will embrace and they will begin to do them. They would also use the facilities here available to also practice. So one, team exposure. Two, most of our surgeons have their surgical loops, but if we could have 1 or 2 extra loops, that would be fantastic. And three, like as you come and visit, and through that we have developed numerous programs. If we have an expert like Jay Agarwal who would come within a week, few days, you know, like I told you, the surgeons here have very sound theoretical basis. Their knowledge is comparable to anywhere in the world. It's just the exposure, you know. So whatever they've read, they know the practice. They can even speak about it, even though they probably have not practiced it before. And hence, when they see in practice alone, and they are made to do one, bingo, you have a microsurgeon in the making. Yeah, so these are areas that I think that you can be of help. One, the resource, the infrastructure, if you have surgical loops. Two, the human resource. If someone visits once in a while, it would be great, you know. That could augment and that could inspire the team. And three, from our part is for us to generate the interest. And already, not only Papa who is developing interest, Emil also has had some exposure in microsurgery in India at the Ganga Institute. It'll be nice to get a nurse to have some exposure as well. And the team is formed. We are ready to have that. And I think that maybe from this discussion, probably this will be the next level we are going to aim for, so that if there's going to be another meeting like this, probably we'll be presenting our experience in microvascular surgery. I read a paper that Sudha shared from Rwanda, very thoughtful. You know, it was amazing what they can do now. I think we can do the same. All right. Thank you, Brett.
Yes, thank you, Paco. All right, I have a question for Kojo. I think you're logged on, and maybe Sadhu. So Kojo maybe just finished the residency or is finishing. Sadhu is a current resident. So recently, Professor Egbedeku asked about the option of Kojo or another coming here for maybe 4 weeks or 6 weeks. And I've discussed that with Dr. Jayaraman and with Dr. Agarwal. And it all seems good. It would still be no scrubbing, no touching, but observing. So Kojo or Sadhu, I'm wondering from your viewpoint, being someone who might be looking towards an opportunity to gain further exposure outside Ghana, what would you see as sort of a perfect situation if you were observing but not scrubbing in? What would make a rotation most valuable for you?
Good evening. Yeah, so
this is Kojo, right?
Yes. Kojo, yes. An external rotation is always beneficial. As you said, hands-on is the ideal because you get to see what is being done because you are part of those doing it. But then, as you said, with your institution and the restrictions, those cannot be done. But then if there could be simulation centers, or if we had a simulation center that did, for instance, as Fiifi said, microsurgery, simulation center that you could just do the autogenous or autologous flaps for, say, breast reconstruction and all that, and the nuances and the new things in these reconstructive processes are adhered to within those simulation centers. At least once our basis, or once my base or theory is sound, just that alone with supervision from yourself or from any other senior person, that wouldn't be a bad idea at all.
Yes. Okay. Kojo, thank you. Sadhu, would you have any other thoughts?
So, yeah, so good evening to everyone. So my input is not too different from what Kojo said. I think prior exposure by way of simulation is very important. As much as one will not have the opportunity, at least if you have a simulation and you are in a better position to appreciate, what is done, than just, appearing without any real exposure. That I think will be very, very difficult. That said, I mean, regardless, one can still pick a lot by way of observation. My first, for instance, Syrian section as a house officer, prior to trying it all by myself, I never really scrubbing because the residents not that they wouldn't allow, there were just too many. So one late night, there was a case, I heard my boss mention that we do it, and I just went ahead. So just an indication of what one can achieve just by way of observation. So I strongly recommend we set up the simulation center, at least in Kumasi, as a preparatory grounds towards, traveling out.
Yes. Okay, Sadhu, thank you. All right. So that we're getting near the end of the time. I just wonder if anyone has any questions or other pertinent comments regarding length of training or fellowship training or collaboration with the Center for Global Surgery.
Yes, I have a word, please.
Yes, Pius.
Hello. Before our meeting with the president today of Ghana, president supports the training program of the college. And we propose that we want to expand to train even in the regional hospitals and some district hospitals in Ghana. And we need personnel to do that. And we need somebody to talk about simulators. Right now, that we're looking for money to start simulation centers in Accra and Kumasi, the tune of $2 million for the both programs, or $1 million for each one. That's a thing that government will consider to help us to build, but government may not get that money. So I'm appealing to our friends in the US through Professor Brad Rockwell to help us raise that, at least part of that money, to start the simulation center in Accra and Kumasi. That would be very good. At the time I was there, I tried to make an impact in the training and get the simulation center in these places. So Brad, please help us to try to get some funds for this. If you could tell some of the authorities, including Global Surgery in Utah, to help us establish this simulation center, because to go along to help our residency training. Thank you very much. That's my word.
Yes.
Thank you.
Thank you, Pius. That would be a great endeavor. Thank you.
Thank
Any
you.
other comments?
I have a question.
Yes. Thank you.
Yeah, well, I'm intrigued. I was going to ask a different question, but before I forget, how much do you need for this simulation project? What's the budget?
It's $2 million. There are
Ooh.
1 million for each one. Each one costs $1 million. And there are two we want to build. One in southern part of Ghana and one in the northern part. Northern part means Kumasi and beyond. And the southern part means Accra and its areas. So two centers, please.
What is this $1 million will buy? Can you give us details?
No, to put out the building and the
sorry?
things that will need, the buildings, building construction.
Yeah,
The
I think
buildings.
Well, I'm talking about equipment. I'm talking about equipment.
yeah,
The equipment that we don't have, we will not produce the list of the equipment yet, but usual things that we need for manicures to train on. Those are things we are thinking about.
yeah, I think Mohammed, he's talking about a surgical simulator, which is
Surgical, yeah.
relatively new in surgical education, but it's sort of having a mannequin or a computer, so students and residents could sort of perform the surgery not on a live patient, but on a simulator.
Simulator.
And
when they've gotten the experience before they go to the live patient.
Right. Yes, it's sort of the.
So how much fund is needed?
Surgery. Well, I think he's saying $1 million
for each one
location, and there would be 2 locations. Yes. Well, we'll keep.
So $1 million just for the equipment, just for the simulator?
No, the building as well. You start from the building structure before the equipment.
So how much do you need for the equipment? Because
Mohammed,
what I'm going to suggest doesn't cover building or constructions, but equipment, yes.
Okay. I will talk to I'm meeting our rector tomorrow. I'll ask him the breakdown, and I can send it to you through Brad.
Yes.
Sure.
Mohammed,
the suggestion I have for you is going through a Rotary. Are you guys familiar with the Rotarians, the Rotary clubs?
Yes.
Yes.
I know there is a bunch of them in Ghana. We worked with them on a different project, not related to the medical. But if you can give us the precise costs of the medical equipment that is needed for this,
yes,
Brett and I can and suit how we can approach the Rotarian here in Utah. And there is a procedure called Global Grant, which involve Rotarian in Utah and in Ghana, but most importantly, it involves the Rotary International Foundation.
Okay.
Thank you, Mohammed. So we would just need like almost a line by line equipment and
Yes.
cost estimate.
Okay. That's a
Yes.
good offer. Thank you so much. I'll take it up.
And we need
I'll take
need
it
to
up. Thank
have
you.
some reliable Rotarian in Ghana that you know
Okay.
that are
Okay.
passionate about this and they're willing to support and then basically communicate with us and basically get involved into the process from the start to the end.
Yes.
Okay.
Great. Thank you, Mohammed. That's
Thank
a
you. Thank
great.
you.
Yes. Okay.
So the other question I have for you guys is for the hand surgery. I'm curious to know which medical conditions benefit from these procedures in Ghana. What is the most common conditions?
Well, for the hand, majority of the cases we see are trauma to the hand. So phalangeal fractures, metacarpal fractures, lacerations to tendons and nerves and blood vessels. Those form the bulk of it. We also have people presenting with tumors, and then we have a congenital hand anomalies, which also forms a chunk of it. We have relatively few neuropathies and then degenerative diseases. So, but majority of it is trauma and then congenital. Yes.
But Papa,
Okay.
Papa Kanaka, the trauma, you forget about the post-band contractures. You have forgotten about that.
Yes, the trauma encompasses all of that. Yes.
But you didn't mention.
Yes, so we also have a significant bit of post-burn contractures and post-burn deformities.
Okay. Well, thank you everyone for logging in from Ghana. Thank you, Papa, for giving the presentation. I think we've reached the end of our time. So we'll sign out if Papa and I can stay logged in, if anyone from Ghana wants to find out what he's been doing for the last 2 weeks. He's been working hard. But thanks everyone. Asuda, thank you as always for this. And in the background is Liz, who helped set everything up today, and Morgan. So thank you, everyone.
Right.
Thank you.
Thank you.
Okay, take care.
Thank you so much.
See.